The next lecture is management of acute combined ACL and posteromedial corner injury of the knee. May I introduce Dr. Tavit Charoensopa from Ekachai Hospital.
Good morning, everybody. I'm Dr. Tavit from Ekachai Hospital. It's my pleasure and my honor to be here. Today, we talk about the management of acute combined ACL and posteromedial instability of the knee. The both ACL and the MCL are the main structure provide rotational instability of the knee. And the isolated case 3 MCL is very rare. Mostly will combine with other ligament, and the most common concomitant ligament injury is the ACL. About the anatomy of the knee, you have the superficial, the MCL, and I will focus on the posteromedial corner. The posteromedial corner is a complex structure that have 5 structures: the POL, the posterior capsule, the posterior horn of the meniscus, and a semimembranosus expansion, and the oblique popliteal ligament. About the biomechanics of the medial side of the knee, the MCL and the posterooblique ligament provide the valgus and rotational stability in the flexion and extension of the knee. This is the reason why you have to pay attention when you have combined injury. If you don't restore the medial structure, it may lead to the failure of another ligament reconstruction. On the physical examination, you should focus if you have the grade T valgus at the knee extension. You have to do the anteromedial rotation instability slocum test. If the positive, that means the patient has a posteromedial corner injuries. On the X-ray, you may not have more information from the X-ray, but maybe you will see the increased middle joint space or the associated fracture in the X-ray. In the acute injury, the X-ray stress test may be the limitation due to the pain and knee effusion. But if you want to do, you should do the intraoperatively after the anesthesia. The MRI is the most helpful investigation to determine the injury structure. When you want to see the posteromedial corner, you should see it on the coronal plane. You will see the superficial MCL. You will see all superficial MCL. After that, you will see the sartorius and the gracilis tendon. Underneath the both tendon is a posterior oblique ligament. And if you see the wavy of the superficial MCL on the MRI, it means the posterior medial corner injury, and they have 75% of the case associated with ACL injuries. How can you treat with the combined ACL and posteromedial corner injuries? How many choices do you have? You can do the operative with ACL and MCL. You can do MCL repair or reconstruction with non-operative ACL. You can do ACL reconstruction with non-operative MCL. You can do ACL reconstruction combined with MCL repair, or you can do the both reconstruction of the ligament. But which one is the best? First, the non-operative treatment with ACL and the MCL. There are only 3 studies that determine in the conservative treatment of ACL and MCL injury. They found that the valgus stability did not restore at the final follow-up and the low rate of return to sport activities. You should consider choice in the patient who don't want to go to surgery or the patient who have a contraindication for surgery. How about the MCL repair or reconstruction with a non-operative ACL? There are 2 studies with the MCL repair and 1 study of the MCL reconstruction. The both studies found the improved valgus stability, but in the IAP they mentioned it still laxity, and they found low rate return to sport activity. They conclude that the ACL reconstruction is a primary factor to improve outcome in the treatment of MCL, and this choice may be not appropriate for the young patient. About the ACL reconstruction with a non-operative MCL, you can conservative the MCL with a hip knee brace for the 6 weeks. And about the weight bearing, you can allow the full weight bearing if the patient have a neutral or valgus alignment. But if the patient have a valgus alignment, you should protect weight with a partial weight bearing. And you must evaluate the stability of the knee at the 6th week. If the patient still have a valgus or rotational instability, the MCL reconstruction should be considered. And this algorithm shows you if you want to do the MCL conservative with ACL reconstruction. First, you conservative with the ACL, with the MCL conservative with a hinge knee brace, and then after 6 weeks, you go to do the ACL reconstruction. Intraoperative valgus stress should do. If the valgus stress are positive, you should do the MCL reconstruction both. But if the valgus stress is not positive, you do just only the ACL reconstruction. This study shows you between the MCL repair compared with the non-operative treatment MCL in the ACL reconstruction. And they divide the patient into two groups for after 2 years. And they found no difference of the stability of the knee, the muscle strength, and the functional score about the two groups. But in this study from the Swedish National Knee Ligament Registry, they report a higher rate of the ACL revision in the patient who have a non-operative treatment of the MCL. About the next choice, the ACL reconstruction combined the MCL repair. Which MCL injury should be repaired except the sternal lesion? From this study, it divided the MCL into the 6 groups determined by physical examination after 6 weeks of injuries. They divide into the grade 1, 2, 3 of the MCL injury combined with the grade A with the negative of Slocum test, and the grade B is the positive Slocum test. All the patients with grade B was done with the MCL repair, and the patient with the grade 1A and 2A had a non-operative. That he found the normal IKDC score and the Lichholm score and the valgus stability are nearly normal. In this study from Dr. Koga show you about result of the ACL reconstruction with the MCL repair. They found a significant improvement of the valgus stability with the KT 1000 and the Lichholm score. About the choice of ACL reconstruction combined with MCL reconstruction, you have so many techniques of the MCL reconstruction, but no study compare about each technique of the MCL reconstruction in combined with the ACL injuries. There are 5 studies of the ACL combined with MCL reconstruction. The 2 studies are comparative, the 3 study left is the case series. All of these studies show you a good result in the AP and the valgus stabilities, improve the functional score, and a high rate return to sport activities. In this study, they show the triangular reconstruction technique for the MCL show more improved rotational stability when compared with the anatomical repair of the MCL. In this meta-analysis, they found no significant difference in the patient report outcome and activity level between ACL reconstruction with a 3 group of non-operative MCL, MCL repair, and MCL reconstruction. And the cruise score, IKDC, and technical score was similar in the all group. In this algorithm for treatment is ACL and the MCL. If you have a sternal lesion, the ACL reconstruction and the MCL repair should do. And the second, if you have a young active patient, you have a 2 choice to do the MCL. First, you do the MCL reconstruction combined with the ACL reconstruction. The second choice, you can do it conservatively with the MCL with the hinge knee brace, then reassess. If the persistent valgus instability, you should do the ACL reconstruction with the MCL reconstruction. But if no valgus instability, just do only ACL reconstruction. In the grade 3, all patients have grade 3 MCL injury. You can conservative first with a hinge knee brace, then reassess again. If you still have the valgus instability, the MCL reconstruction should be done. In the summary, in the combined injury with ACL and the MCL, the posteromedial corner should be addressed. The ACL should or must be reconstructed, and the MCL or the posteromedial corner should be treated with brace or repair or reconstruction to restore the valgus and rotational stability. Thank you.